I'm Dr. Oni Blackstock. On behalf of CME Outfitters, I'd like to thank you for joining us today and welcome you to today's educational activity entitled Disparities in HIV Care, the Mounting Epidemic Plaguing African Americans. This educational activity is supported by independent educational grants from Gilead Sciences Incorporated, Janssen Therapeutics Division of Janssen Products, LP, and ViiV Healthcare. These supporters were not involved in the development of content or selection of faculty for this educational activity. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Today's CME activity is also eligible for ABIM MOC points, so make sure you engage in today's event, answer polling questions, submit questions, and provide your feedback. Once you complete today's program, be sure to provide your ABIM ID and birth date in the evaluation. CME Outfitters will submit your MOC points. You can also claim this activity as CME for MIPS improvement activity, so please make sure to participate and provide examples of how you will change your clinical practice. And CME Outfitters will send you confirmation of your participation, which you can submit to CMS. I also want to encourage everyone to join us today on our live Twitter conversation at CME Outfitters. We will be monitoring the Twitter feed and responding to your tweets as they come in. I also want to note that we are using an enhanced platform today that allows you to save slides, take notes on slides, answer polling questions, and send us your questions. We will be taking questions throughout the program, so no need to wait till the end to submit. So as I mentioned, I'm Dr. Oni Blackstock, founder and executive director of Health Justice in New York, New York. Let me first welcome my colleague, Dr. Carlos Malvestuto, assistant professor in the Division of Infectious Diseases at Ohio State University's Wexner Medical Center in Columbus, Ohio. Welcome, Carlos, and thank you for joining me.
Hello, it's a pleasure to be here.
Great, wonderful. Also with us is my colleague, Dr. Leandro Mena. He is chair and professor of population health sciences and professor in the Division of Infectious Diseases at the University of Mississippi Medical Center in Jackson, Mississippi. Welcome, Leandro, and thank you for joining me today.
Oh, thank you for the invitation to be here.
Okay, wonderful. So our learning objective today is to actively engage Black and African Americans at risk for HIV in testing, treatment, and educational initiatives. Before we move into the data, I would like to get our audience involved. You will see the question on your screen and you can choose your responses now. So the question is, in the TRIO Health Study report, which of these statements is not true regarding the differences in HIV viral suppression? Your choices are: 1, Black and other people of color have higher rates of viremia than whites. People with HIV treated in the South have lower rates of viral suppression. 3, Medicare and commercial insurance patients have equal rates of viremia. 4, there were no differences between gender and rates of viral suppression. Or 5, I'm not sure. Please go ahead and vote now. Okay, and so the answer is 4. There were no differences between gender and rates of viral suppression. So moving on, just say in my previous role as assistant commissioner at the New York City Health Department, where I led the HIV program, one of the primary issues that we were confronted with, and probably is the case for most people around the country, are that Black communities are disproportionately affected by HIV. This graph shows the numbers for new HIV diagnoses in the US and other dependent areas for the most affected subpopulations. And as you can see, Black men who have sex with men have the highest number of new HIV diagnoses, followed by Latino men. And then that Black cisgender women have among the higher diagnoses among women. So moving on, Leandro, I know that you've also seen these racial disparities firsthand in patients with HIV in your work in Mississippi. What can you tell us about the cascade of care when it comes to men who have sex with men?
Yeah, Oni. As you show in your prior slide, men who have sex with men are disproportionately affected by HIV. There are significant disparities, racial and ethnic disparities. Likewise, disparities in HIV incidence and prevalence among men who have sex with men are also present across the HIV care continuum with important implications for race-specific transmission rates. As we see here, Black MSM are less likely to be diagnosed with HIV, less likely to be retaining care, less likely to be on ART, and at the end, only 16% of Black and 34% of white MSM achieve viral suppression. These disparities in HIV transmission rates can be reduced, but we need to improve the HIV care continuum outcomes for individuals of color.
Yes, so there's definitely much work to be done and a number of barriers impeding engagement in HIV treatment. Carlos, access to care is one of the key issues we know. What do disparities to access in HIV care include? What are some of those barriers?
So as we can see in this chart, white adults with HIV are more likely than Blacks and Hispanics to have private insurance and Medicare. And they're also less likely than Blacks to have Medicaid. So most notably, here we can see that Blacks and Hispanics were more than 3 times as likely as whites to be uninsured. So these trends reflect in part disparities seen in coverage by race and ethnicity nationwide, including that people of color are more likely than whites to live in non-Medicaid expansion states. The lack of insurance also leads to more limited opportunities for HIV testing and for prevention through PrEP. This is why many of our newly diagnosed patients of color will present with more advanced disease and may have never been offered an HIV test previously. So it's important to make testing widely available. For example, in my own location in Columbus, Ohio, we have worked very closely with our community hospital emergency departments, which many of our uninsured patients use as their primary point of access to healthcare to support and improve the rates of HIV testing. And over the past 3 years, there has been a very significant increase in HIV testing as well as STI testing that we have then supported with rapid linkage to care. So it's important to be able to provide access to testing and to PrEP in all the locations where patients who don't necessarily have regular access to medical care could be found.
Yeah, so Carlos, you mentioned access to HIV testing, treatment, and to PrEP, and PrEP being a critical part of addressing HIV disparities. I'm wondering if you can tell us about this study on this slide and others that you've mentioned about PrEP.
Sure. So in this particular study, they surveyed 1,464 HIV seronegative patients who visited 2 public Baltimore City Health Department sexual health clinics in 2016. Overall, only 18% reported prior knowledge of PrEP. And this has been a problem that we see really nationwide. Only about 4% of these patients who were attending the sexual health clinic were already using PrEP. Importantly, 46% of 1,397 patients who were unfamiliar with PrEP indicated that they were highly receptive to learning more about PrEP. So with interest among high-risk men who have sex with men, even higher at about 63%. So this study and many others, many similar ones across the country have found that racial disparities around PrEP awareness, with white participants' awareness being twice as high as Black participants' awareness. And PrEP awareness among white participants here was 34% versus 16% only among Black participants. So this disparity in PrEP awareness is really quite alarming, especially considering the elevated risk of acquiring HIV in Black communities. So we know that Black men are over 6 times as likely to acquire HIV during their lives compared to white men. And the lifetime risk is 17 times greater among Black women than white women. Another important finding from this particular study was that healthcare providers are the primary source of PrEP information. So 32% of 258 participants who indicated prior awareness of PrEP reported that they received information about PrEP from healthcare providers. Beyond healthcare providers, participants also identified friends, television, and the internet as additional sources of information. So overall, this study and others highlight the importance of providing information about PrEP to all at-risk individuals, since about 50% or so are highly receptive to learning about PrEP. If we can provide convenient access to HIV testing and PrEP initiation, we should be able to increase PrEP uptake in communities of color. There are great examples of innovative programs to increase access to HIV testing and to PrEP, such as the use of mobile vans to provide HIV and STI testing, and even initiating PrEP outside of the traditional medical centers.
Thank you, Carlos. In your remarks, I know you mentioned the ER as being a frequent site of people seeking care, and we received a question from the audience about whether there's data around why people of color use the ER as a point of care, are more likely to, and that may also be related to some of what you were talking about related to insurance. And if the patient in the ER is seen and they test positive, whether treatment can be started in the ER, or if they test negative, whether PrEP can be started in the ER?
Yeah, so those are great questions. Yes, regarding why is it that we tend to find more people of color utilizing the ER as their primary point of access to healthcare. So it has to do with lack of insurance, so uninsured status, and also convenience. So for many patients, being able to take time off, or even for patients who may not have benefits at work that wouldn't allow them to leave during the day to be able to go to a medical appointment. So then having access to the emergency department or urgent care then makes it more convenient for those patients. So it's important to use that as an opportunity to then provide information and also provide access to HIV testing. We have actually established a nice program actually with our emergency departments in the city of Columbus. And we've been able to increase HIV testing. What we've done is actually provided the support so that we get reports of any positive HIV test results so that we can immediately start link patients to care. If they test negative, then they would be linked to PrEP services. And if they test positive for HIV, then we link them to start ART as soon as possible. So we've been able to actually get patients then seen in our clinics and started an ART within 7 days of that initial diagnosis. Now, starting ART in the emergency department presents a number of challenges and may not be, it's something that has been discussed, but it's not something that is usually could happen in that setting because it requires a lot of pieces to be in place. However, as we will discuss later on, much like the examples that we have for sexual health clinics, where we can start ART on the date that somebody tests negative, that is something that we're also exploring to be able to do in emergency departments.
Okay, thank you so much, Carlos. So moving on, the regional and racial disparities in response to ART, antiretroviral therapy, is the study we mentioned in the first question that was posed to the audience. Leandro, what did the study show about people living with HIV?
This is a really interesting study. I really like it. And I like it because, this study presented an evaluation of the differences in viral suppression by race and region among people living with HIV in care at 10 community practices that really represent examples of what happens in the real world outside of clinical trials. What they found is that younger individuals, Black individuals, other people of color, those treated in the South, those with Medicaid or uninsured, and those on multiple tablet regimens were less likely to be virologically suppressed. So again, it's real life, real world data of who are the key populations who are more vulnerable and less likely to achieve viral suppression. I think, Carlos touched, on some of the factors that really represent, the challenges that we have ahead of us in order to make sure that we can end, HIV for all by 2030.
Great, thank you, Leandro. One question that came in from the audience was asking why do we see higher rates of virologic failure on antiretroviral therapy among people of color, Black people? Are they given different treatment than white populations? Is that something that, Leandro, you want to take a stab at addressing some of those factors? Thank you.
Sure, that's a great question. We know that there's nothing, there's nothing biologically, right, that explains this difference. I mean, we know there are some, sex differences in how some medications are metabolized, but we know that the biggest differences in outcomes between Black people and other individuals. As a matter of fact, when you analyze, race and ethnicity, once you control for socioeconomical data, very often the difference that you see between whites and Hispanics cannot go away. With Blacks, the difference remain. And primarily, as it was mentioned, and we'll talk about it in the next slides, many of the differences are because of lack of access to care and some of the things that Carlos mentioned. People are less likely to be insured. People are less likely to have jobs that have paid leave. People are less likely to have issues around health literacy and again a whole set of issues that derive from the legacy of racism and discrimination that we have in our country.
Thank you, Leandro. And I know there's a question from the audience around medical mistrust. Some of these topics that are being asked about will be covered in some of the subsequent slides. So just hold tight. So before we continue with some of the contributing factors to HIV care inequities, I want to ask you, the audience, a question. Which of these factors do not contribute to HIV disease burden among Black Americans? And the choices are limited access to healthcare services, 2, healthcare inequities and inequalities, 3, higher rates of high-risk behaviors in persons of other races, 4, poorer rates of linkage and retention in care, and 5, I don't know. So we'll give you some seconds. Great. So thank you, everyone. So the response that was correct, the correct response was higher rates of high-risk behaviors than persons of other races. That's a factor that does not contribute. Black people do not have higher risk behaviors than other races. But perhaps we can just dig a little deeper into some of the evidence around that data. I don't know if Leandro or Carlos, if you want to just address that point around higher rates of high-risk behaviors than persons of other races, how this is not an explanation for the inequities that we see?
Oh, absolutely. I think, I'm glad, pretty much, the audience, had it right. It's important to always state, that Black or African Americans do not engage in any more high-risk behavior than persons of other races, but they have poorer outcomes for diagnosis, linkage and retention in care, ART prescriptions, adherence and viral suppression. These are, the result of many factors, as I mentioned before. But some of the key ones are the limited access to health services, lower levels of health insurance, HIV-related stigma, HIV rates and high HIV rates of incarceration. In my clinics, 10% of no-show appointments, either to clinical visits or to research visits, are connected to individuals, dealing with things that have to do with the criminal system. Either they have a meeting with their parole officer, or they have a court appointment, or they happen to be in jail. If you take a random sample of individuals living in HIV Mississippi, 10% of individuals are going to be in jail at any given time. And I think that's a problem, jail or prison.
Yes, absolutely. We see, this is very similar, to what we see in Columbus as well, where, we know very well that the increased rates that we see are not associated with increased risk behavior. But more limited access to healthcare, the stigma that goes with addressing risk or discussions around risk. So, all of these are important contributors to these worse outcomes in people of color.
And we see in this slide, a long list of many, individual level factors, provider factors, system factors that affect linkage and retention in care. I think that they all, not all are at the same time, but they all can be present. And I think, for providers, it's so important, to be aware of these factors, to acknowledge them, and ask and address them, right, whenever it's possible, because they're really going to help in the building, the relationship with the patient, right? People at the end recognizes, that you care when you ask and you explore these things.
Yes. I'm also wondering, there's a few questions that have come in about maybe the role that providers play in some of the inequities that we see in terms of potentially provider bias and what role that might play in whether providers decide to, prescribe a patient HIV treatment or PrEP. Would you, either of you be able to speak to that, the role that providers may play in contributing to some of these inequities?
Yeah, I can tell you that when it comes to PrEP in particular, sometimes, so what we see is that the uptake of PrEP, which really should be happening at the primary care level, but that really doesn't seem to happen in many places. So, for example, even here in Columbus, what we've been working at increasing the uptake of PrEP, but it's been happening very slowly. But many of our patients who come to us, at our infectious disease clinic and get started on PrEP with us, tell us that if they do have a primary care provider, the provider may not be asking them or may not even be aware of their sexual orientation and may never ask questions about risk behaviors and what the patients can do about those. So it is, and this goes back to either a level of discomfort at the provider level, or at the same time, making certain assumptions about risk. But it is very important to have that open conversation with patients and to address each of these barriers that we see. And if we do this just regularly and systematically, then that's how we can make sure that we are identifying patients who really would benefit from being offered an HIV test and also being offered PrEP in particular.
Great, thank you, Carlos. So just, I think, sort of related to some of these factors that can affect engagement in care, we've been hearing a lot about medical mistrust in the context of the COVID-19 vaccine, but it's also relevant when it comes to other types of care, such as HIV care and PrEP. Medical mistrust, we know, has both longstanding historical implications as well as present day reasons for its existence, and we know that it's very valid and justified among marginalized groups. Leandro, how does medical mistrust play a role in the HIV outcomes that we see?
Absolutely. I mean, I think again, it's important to understand that individuals come to us often with a long-standing history of experience racism and discrimination that naturally makes them less likely to trust the medical system. And as we are part of the medical system, we're less likely to be trusted. As a consequence, people delay care and are less likely to adhere to our therapeutic plans. So again, it's important to recognize, because one of the things that very often these items are passed, from generation to generation, are transferred, with very little communication. So people is sometimes, unable to articulate, how they feel. But so it's important that we come from a space of a space of empathy, and cultural, humility, when we approach our patients and we discuss, therapeutic plans, and making sure that people, are, being heard as we, talk to them about their life and their health.
Yes, thank you so much, Leandro. And then just moving on, maybe share with us some of the ways in which medical mistrust actually impacts HIV-related outcomes. Oh,
Sure.
sorry. They say Carlos. I meant Leandro. I'm so sorry. Yeah.
Yes. So yes, I mean, as I say, there are many ways. I mean, medical mistrust can lower uptake of HIV testing. As I say, people delay care. Why people will go somewhere, unless they really need it, if they don't feel comfortable, with whatever service is provided. So we've seen how medical mistrust can lower uptake of condoms. People are less comfortable talking to their providers about PrEP, and there is lower PrEP awareness and uptake. It also lowers the likelihood to believe HIV treatment is effective. It lowers antiretroviral adherence. I mean, if you don't think, the medication is going to have an impact, it's going to do anything to you, why will you take it? And as a consequence, again, affects, we talked about earlier, in terms of the outcomes across the care continuum. People are less likely to be biologically suppressed, and overall to be engaged in HIV care.
Yes. And so moving on to thinking about what are models that have been developed to really try to address some of these HIV-related inequities. There's the Jumpstart program in New York City. And it's a model that can be replicated and scaled up. And Carlos, you've discussed HIV sexual health clinics for improving access to testing and treatment. Can you tell us a little bit about the Jumpstart program and what the program has seen in terms of results?
Sure. So this is an example of a great program out of New York City sexual health clinics that provided immediate or rapid access to ART for patients who tested positive for HIV. So in sexual health clinic, patients in New York are routinely tested for HIV via a rapid antibody test. Individuals at highest risk are also screened for acute HIV using pooled nucleic acid testing. And then patients eligible for this program were 18 and older. They lived in the state and reported no prior antiretroviral treatment. So what did this program include? So initiation visits included providing a 30-day supply of antiretrovirals, medical navigation, medical monitoring, and linkage to an HIV primary care clinic. So the idea is that within that 30-day period, while the patient was already started on ART, then that should be sufficient to then be able to follow up in an HIV primary care clinic. If linkage to care was not achieved within that 30-day period, then they could receive a second refill at the sexual health clinic. So this was in this descriptive analysis of the participants in the program, and this was 149 participants who were seen between November of 2016 and July of 2017. So they described pre-treatment, drug resistance patterns, CD4, viral load, time to viral load suppression. And as we can see in the next slide, there were 149 patients who initiated antiretrovirals. Of these, 108 were newly diagnosed at the sexual health clinic. So 72% of these initiated ARV on the date of diagnosis, which was actually fantastic. So sorry, 72% initiated ARVs, and then 50% of those initiated on the date of diagnosis. But of those who didn't initiate it within the date of diagnosis, 87% initiated within 7 days. So really, this was did great at actually getting people started on ART as quickly as possible. So they found that 85% of the new initiates on ART, 85% were men who had sex with men. 67% of these were Hispanic or Black. And then the median age was about 29. Interestingly, about 10% had acute HIV, and about 17% had advanced HIV disease with CD4 counts less than 200. So again, this is a great example of a program that by offering immediate or rapid ART initiation, then patients are able to start an ART right away. And then what was shown was actually that it was very safe to do this. There was only one participant who had to be switched under ART because of prior resistance. There were some participants who actually had pre-existing resistance mutations, but it was mostly to NNRTIs and did not really present in most cases reasons to change the regimens, and we'll talk about regimen initiation later on. So with what we have available now, it is actually very possible to be able to do this very safely. And overall, the results speak for themselves. So among those with viral load testing at follow-up, 87% had achieved viral loads suppression by day 45. So again, a great model which has been replicated in other sites, and it's actually something that we've used this as our model for our own program here in Columbus as well.
Thank you, Carlos. It's very exciting to hear about that model. And just wanted to answer a question that one of the audience members had about HIV education in sexual health clinics for adults and for teenagers. And just to say from my own experience here in New York City with our Department of Health sexual health clinics is that yes, sexual health education and in particular addressing issues around HIV and HIV prevention is a really big part of the services that are delivered at sexual health clinics. And I would assume that's the case for many other jurisdictions as well. So moving on to the next slide, just in terms of thinking about optimizing HIV treatment adherence for Black Americans who are living with HIV. You know that one factor in some of the lower rates of PrEP use and HIV treatment among Black Americans can be again related to healthcare provider discrimination or bias when it comes to adherence. So we know that there are biases and stereotypes that healthcare providers might have regarding adherence when it comes to HIV positive people of color. This might, again, affect providers' treatment decisions and potentially lead to failure to treat certain patients, as well as delaying the timing of HIV treatment initiation. You know that most studies show that Black Americans and other people of color have, again, similar adherence to antiretroviral therapy as other patients. After other key factors related to adherence are addressed. Yet in real life, we know Black Americans are more likely to experience one or more barriers to adherence compared to their white counterparts. So just thinking about the training that healthcare providers need and that they and their patients could benefit from, maybe Leandro, maybe you can tell us how training can impact these outcomes.
Yeah, no doubt, there is great evidence that training can improve provider effectiveness when caring for minority populations. The first thing is addressing implicit bias that we all have to manage, so our biases, don't affect the care that we provide to our patients. We have to be proactive, to combat biases, and there is, available, implicit bias, test. There's the Harvard implicit bias assessment. And training, to address bias among healthcare providers is so important. As we care for African Americans, for individuals of African heritage, it's important to acknowledge and address the racism, the systemic racism that exists in our institutions. When we think about healthcare, healthcare in our country was designed for kind of individuals, right? People who have insurance, people who are middle class, people who have some kind of education that can navigate the healthcare system. So then you have to ask, yourself, if our patients, represent that population, and if the answer is no, we have to start changing that system, so it can make sense, for them in a way that has not done before. It's important to educate ourselves, how to respond to mistrust. I mentioned some of these about, empathy, reflective listening, listen to our patients, really listening, and learning a little bit about our patients, getting to know them a little bit better. Into what they do, how they prefer to do things. In our clinics, we tend to have this, shared decision-making approach. When you talk to the patient and tell them, these are the choices and these are the things that we think you should be doing, how do you think you can do this? I mean, sometimes, we have to go down to how many pills do you think you can take, and go from there and work with the patient. I think it's important to encourage questions and make sure that people is understanding and not making assumptions is very important, and being non-judgmental and non-confrontational with patients. Again, it's important to acknowledge historic and current context of discrimination and racism as root cause. And what really helps, is to have a diverse healthcare, professional body. I mean, and sometimes, I mean, we know that you know, Blacks and Latinos are underrepresented among physicians. It may not be possible to have in every single clinic, you know, a Black or Latino patient to take care of Black or Latino patients, but you can have other healthcare professionals, you know, who can, you know, serve as a liaison, you know, because people will connect with people, you know, and I think, you know, that's where ambassadors, peer educators, that's where social workers, you know, anyone, you know, in your clinic can be that person that connects with patients. I think in the extent that we can empower them, you know, healthcare professionals working in the clinical spaces, you know, to support those patients, to provide an education that will improve in engaging those patients to care.
Okay, great. Thank you so much, Leandro. And I think so much of what you mentioned also addresses one of the audience questions about the best way to combat medical mistrust, all of those steps that you talked about in terms of acknowledging and addressing racism and educating on how to respond to mistrust. All of these steps can help to engender trust in relationship. So thank you, Carlos and Leandro. And to wrap up this module, I'd like to highlight our takeaways and action steps for the audience. And so those are really to identify opportunities in your practice or your healthcare settings to improve HIV testing and linkage to care for Black Americans, to educate your healthcare team about the historical and present day context of medical mistrust, and then lastly, to confront biases and stereotypes about adherence among people of color who are HIV positive in order to avoid and mitigate treatment delays. Okay, great. And so our goal for this next segment is really to develop treatment strategies for older adults with HIV to optimize health outcomes. Let's start by involving the audience with a question. This question reads, bone health is a concern among older adults on antiretroviral therapy. Which of the following is not a DHHS guideline recommendation about osteoporosis? Is it TAF and abacavir are associated with smaller declines in bone mineral density than TDF? 2, TDF has been associated with increases in bone mineral density, renal tubulopathy, and resultant osteomalacia. 3, abacavir may be used if a patient is HLA 5701 negative. 4, if HIV RNA is greater than 100,000 copies per milliliter, do not use abacavir. And 3, TC plus efavirenz or atazanavir with ritonavir, or 5, I don't know. Please choose your answer now, and we'll come back to the results a little later. Great. Okay, thank you everyone for putting in your responses. So almost 50% of people living with HIV in the United States are 50 years and older, and this is projected to increase by 23% by 2025. Carlos, can you share with us what are some of the factors contributing to an older HIV population, and what is this ultimately?
Sure. So as our population of people living with HIV ages, the prevalence of comorbidities increases, and the need to manage these comorbidities becomes pretty much as important as maintaining HIV viral suppression. And you know, a lot of the problems that we've been discussing so far, so lack of access to healthcare, or more interrupted healthcare, which then leads to issues with treatment adherence, for example, then will also translate into both the diagnosis and management of comorbidities like hypertension, diabetes, kidney disease. Many of these that we see overrepresented also among African Americans, which again, you know, due to a lot of the same reasons. So as we can see in the next slide here, then we have chronic immune activation and inflammation due to HIV, will contribute to accelerated aging and earlier presentation of frailty, renal impairment, and also an increased risk of cardiovascular disease. It becomes particularly important also to avoid drug interactions between antiretrovirals and medications to treat comorbidities such as diabetes, hypertension, and dyslipidemia.
Okay, great. So there's a lot that people living with HIV and aging with HIV are having to deal with. The Pearl model projects on the healthcare needs of older people living with HIV. And Leandro, how is this population unique, and what are some of the treatment considerations that providers need to take into account? Oh.
Carlos mentioned, the population living with HIV in the United States is aging, and the projecting age multimorbidity and polypharmacy study, a group also known as Pearl, developed a model where they, model the increase in the number of individuals taking ART in the United States to be almost 1 million adults by 2030. The mean age of ART users by 2030 will be 53 years, and the group that will experience the largest growth will be those 60 to 70 years. 1 in 4 adults on ART will be 65 years or older. This has important implications for the health needs of these individuals, as it is anticipated that 36% of all people taking ART will have 2 or more comorbidities. You can see in the table on the right, where it shows the projected increase by 2030 of common comorbidities. They're all increasing. So again, we have to be prepared in terms of primary care workforce that will be able to take care of the needs, the increased needs of aging individuals living with HIV. So it is important, as we care for individuals who live with HIV, that we work with them to address all modifiable contributing factors that may improve quantity and quality of life. In a recent study presented at CROI this year, Umbrella and collaborators from the REPRIEVE study presented on physical function and frailty on middle-aged people living with HIV. Among 266 people living with HIV, physical function impairment and pre-frailty were present in nearly 50% of individuals. Hypertension was present in 28%, overweight in 38%, and obesity in 30%. Older age, Black race, 10 years on ART, greater BMI, high waist circumference, hypertension, and physical activity were all risk factors for frailty.
Thank you so much for sharing that. So as we mentioned, for cardiovascular disease, can be a leading cause of morbidity and mortality. It is a leading cause for older people living with HIV. Carlos, what do we know about the risk of cardiovascular disease in people living with HIV, particularly older people?
Sure. So I think it's very important to recognize that the majority of our patients who are on ART, they'll do well. Their HIV will be suppressed, so they will not die as a result of advanced AIDS and opportunistic infections. But their main cause of death with this aging population is cardiovascular disease. And I try to emphasize to my patients and also to colleagues that HIV itself is an independent risk factor for cardiovascular disease. We know now from multiple studies that chronic inflammation leads to accelerated formation of plaque in arteries, and the risk of cardiovascular disease goes up at anywhere from 75 to 100% in people living with HIV. So there are now trials like the REPRIEVE trial that aim to identify interventions that may reduce this excess risk. But in addition, it also makes it particularly important to work with patients to make them aware of the fact that they're at increased risk of cardiovascular disease, which also means that it's particularly important to really address traditional risk factors, such as smoking. And we know that smoking is highly prevalent in our patient population, as well as improving diet and exercise. It is very much a part of what we should be doing as part of taking care of HIV in our patients.
Great. So cardiovascular risk obviously is a concern, and we know from the audience question that we posed before that bone health is also a significant concern when we're thinking about people living with HIV, especially older people living with HIV. Leandro, why is this issue more of an issue for older people with HIV in particular?
It's important to recognize that the prevalence of frailty in HIV negative individuals is actually very low in the age group of 40 to 50 years old. While in people who are HIV positive, it is significantly higher. In some reports, anywhere between 5 to 28%. So in a veteran aging cohort study, frailty increased 5 years risk of hospitalization by 78% and mortality in HIV positive individuals. So earlier diagnosis and initiation of ART, as well as reinforcement of adherence to therapy, can decrease frequency of risk factors. Also, ART treatment decisions should factor in the impact that they may have in bone health. Frailty is an important predictor of morbidity and mortality. So data here from the LIFE study was used to examine the relationship between frailty in HIV and survival rates. And here we can see, after adjustment for sociodemographic factors, the number of comorbid conditions and HIV disease status, being frail at 1 or 2 consecutive visits was associated with a significant higher mortality rates than those who maintain a non-frail state. So again, frailty is something that should be, diagnosed early, and treatment decisions, should be done to diminish the impact of factors that may contribute to frailty.
Okay, great. Right. So then, when thinking about bone health, how does that impact overall treatment decision making?
Absolutely. You know that there are, drugs, that we use, commonly drugs, the common drugs that we use to treat HIV that can have an impact in the bone health. TDF, the tenofovir disoproxil fumarate, which is, part of the TDF emtricitabine combination, can decrease the bone mineral density of individuals taking the medication for a long time, and can produce osteomalacia or exacerbate osteoporosis. So individuals who are at risk of osteoporosis should avoid using TDF. Abacavir, can be used instead in individuals who are HLA B5701. And if the HIV RNA is over 100,000, it's important not to use abacavir 3DC combination with the favirenz or atazanavir boosted with ritonavir.
Mm-hmm. Yes, so we know that, so cardiovascular risk is a concern, bone health. And what about renal disease, renal comorbidities? How much of a concern are those, Carlos?
So, and people living with HIV have a greater risk of progressing to end-stage renal disease than the general population. So part of this has to do with the prevalence of other comorbidities such as hypertension and diabetes that without adequate control then would lead to an accelerated progression of chronic kidney disease. As a matter of fact, for many of our patients who are newly diagnosed with HIV, we end up diagnosing hypertension and diabetes that they may have been unaware of, prior to that diagnosis of HIV. In some ways, sometimes actually going into care for HIV allows them to then go into care for management of their comorbidities such as hypertension and diabetes. Long-term ART exposure does contribute to the burden of renal disease, but we know that a lot of our current ART options are less likely to contribute to this, except as we discussed before in the case of TDF, but now we have options such as, for example, TAF, which are safer from a renal standpoint. It's also something that we are well aware of, that in terms of racial and ethnic differences, that for patients with advanced disease, HIV-associated nephropathy is seen almost exclusively in Black men and women. But fortunately, it's something that we don't see as much as we used to, although in patients with advanced disease at this AIDS at the time of diagnosis, then this may be an initial presentation as well.
Okay, great. And I'm wondering, this might be a decent time to ask this one audience question. Carlos, you had mentioned about people living with HIV, once they're getting into care, they're also getting care for some of their other chronic medical conditions like diabetes and hypertension. One of the audience members asked, does the higher rates of diabetes and hypertension in Black Americans skew the result for HIV in older adults? So they're wondering whether the sort of underlying high rates of diabetes and high blood pressure in Black Americans is also contributing to the high rates that we're seeing in older adults who are Black American and living with HIV.
I think it certainly does contribute to some, a lot of the complications that we see and the accelerated progression of, for example, kidney disease and the earlier onset of cardiovascular disease, where HIV alone is already an independent contributor, but added to that, what we tend to see is other risk factors that we then will also contribute. So not only is HIV contributing to more rapid progression to cardiovascular disease, but also previously untreated hypertension, previously untreated diabetes. So, which is why it's so important to then look at the entire picture. And for our aging patients, it becomes much more challenging because we obviously we have to treat the entire patient and all of the comorbidities, not just the HIV alone.
Right, right.
And I think, one of the points is that all these diseases are chronic diseases, which incidence will increase with age. So they don't go away. They will progress as people ages. And I think what we have to anticipate is the fact that as the HIV population is, aging, right, the prevalence of these diseases is going to increase, especially on individuals who have, conditions, right, predisposition, either because of family history or other factors.
Okay, great. Yeah, and so we were talking a little bit about so the impact of comorbidities on treatment choice, and then are there any racial and ethnic differences among people with HIV in terms of the prevalence of these comorbidities? I think we got at this a little bit, but as far as Carlos or Leandro, whether there are racial ethnic differences in prevalence of some of these chronic medical conditions in people living with HIV.
Right. I think Carlos mentioned, the rates of chronic kidney disease, hypertension, diabetes in African Americans are much higher than what they are in whites. So again, if you add HIV into the mix, then that independently, can contribute to kidney disease and heart disease, it has an additive factor.
Okay, thank you both. So moving on, just thinking about sort of determinants of our adherence in older adults, that older adults with HIV may face some unique factors that may affect their adherence to HIV treatment. And some of these include economic factors. We know many older adults may be on fixed incomes, education, stigma around HIV. There are also age-related cognitive declines that also happen in addition to cognitive declines related to HIV, mental health, social support, healthcare access. All of these can play roles in terms of, contributing to either being barriers or facilitators to adherence. So just moving on, Leandro, the previous slide mentioned age-related cognitive decline as it relates to HIV treatment. What about cognition in general in people with HIV? What can we say about that?
Oh, people living with HIV may develop a spectrum of cognitive, motor, and/or mood problems, collectively known as HIV-associated neurocognitive disorders or HAND. So it's important to recognize that about half of adults living with HIV will experience HAND, which can compromise everyday function and quality of life. With the aging HIV population, age-related cognitive declines may exacerbate HIV-related cognitive deficits. So it's important for people living with HIV to really be aware about the potential of these issues and not what to expect and how to manage these. So adults with HIV may benefit from education about how lifestyles and health behaviors may improve brain health and cognition as they age.
Okay, great, thank you. Let's see, there were some questions that came in from the audience, and some of them will be answered in some of the subsequent slides. Someone had a question about what percentage of older adults with HIV are people of color. Are there more older white people with HIV simply because they receive timely care and achieve viral suppression. So this is wanting to know, like, I think whether the breakdown of people of color might be greater among or less among older adults as compared to the overall population of people living with HIV. I don't know if either Carlos or Leandro, if you want to take a stab at that.
You know, I think in general, there are more white people living with HIV, period, right? You know, and I can tell you that because of the factors that we have mentioned, and I can, you know, 10 years ago, I lived in Jackson, Mississippi. I was very interested in doing a study with older people living with HIV because I was interested in trying to understand the needs of that aging population. And I live in Jackson, Mississippi, and when I started looking for older people living with HIV who were Black, I couldn't find anyone above 65 years old, right? You know, but again, because of the factors that we have talked about, right? We know that African Americans or Black are less likely to be on treatment, less likely to be adherent to medication. And as a consequence, many of them, you know, are less likely to benefit, right, from a HIV treatment and from the benefits of being biologically suppressed, you know, and what it does in terms of decreasing the incidence and not only HIV related, you know, morbidity, but also, you know, malignancies and other, you know, diseases that are not HIV related. So African Americans have a much higher HIV adjusted mortality rate, you know, than people of other races. So I think that's, I don't know if I answered the question, but and I can give you the exact, I know that nowadays, you know, about 50% of all new HIV infections are among African Americans. So as time goes by, you know, I can foresee the time where African Americans will become, right, the largest proportion of individuals living with HIV. But right now, the majority of people living with HIV are white. But in part, it's because they're more, but the other part is because they are, you know, the life expectancy is better because more of them, you know, a larger proportion of them are engaged in treatment.
Right, and I think, so Leandro, you know, explained it very clearly. So currently, you know, if you look at our oldest patients in our clinics, you know, it is still majority white. But as you look at the younger cohorts that are now living with HIV, and, you know, it's now this aging population, so we see that will shift. It's very interesting. So for example, in my clinic, I have a number of patients who are in their late 70s and even early 80s who have been living with HIV for close to 3 decades. And when you go back, you see that these patients were the patients who had access to, for example, the early clinical trials, who maybe had access to protease inhibitors as soon as they came out. And at that time, this was mostly, you know, wider, it's a white population of patients, particularly men, white men in particular. So, you know, they've managed to then stay suppressed now on their antiretroviral treatments, whereas a lot of the people of color who were diagnosed, you know, back in the 80s and 90s you see very few of them around in our clinics. But that is shifting. And I think it is important that we recognize that the entire population of patients living with HIV is aging, and for good reason, because, you know, now HIV is no longer a death sentence. So, you know, it's a chronic condition that we need to manage. But I think the key is to be able to emphasize to all our patients, how do we make sure, and to take a preventive approach, how do we make sure that you will be as healthy as possible in the next 10 years? So not just dealing with, you know, the complications that come with these comorbidities, but trying to prevent, you know, that cardiovascular disease, trying to get better management of diabetes and hypertension now to then avoid the consequences of advanced kidney disease later on, for example. So, you know, it is something that, you know, all of our people living with HIV, that it is very much an aging group that we're seeing.
Definitely, definitely. Thank you both for those very rich responses. So before we wrap up this segment, let's revisit our audience response question. It said, bone health is a concern among older adults on antiretroviral therapy. Which of the following is not a DHHS guideline recommendation about osteoporosis? and the options were TAF, and I think we read the options before, and so the answer was TDF has been associated with increases in bone mineral, I think it should be decreases in bone mineral density. Oh yes, sorry, increases in bone mineral density, renal tubulopathy, and resulted osteomalacia. So that is the response. Hopefully everyone got that. And then I don't know if there anyone who had to change their response, but hopefully from the discussion, it will be clear to you why number 2 is the correct answer. Okay, great. So thank you, Carlos and Leandro, for your valuable insights on the health of older people living with HIV. So let's summarize our goals for this segment. They were to factor comorbidities such as cardiovascular disease, hyperlipidemia, bone health, chronic kidney disease and neurologic disorders into treatment decisions in older people living with HIV. Also to screen for cognitive decline and mental health as contributors to poor HIV-related outcomes, and also to be aware of the social determinants of health that may negatively impact outcomes in patients living with HIV. So now we're moving on to our final segment. In this segment, we aim to provide you with the evidence and the strategies to help you integrate best practices for initiating and switching patients to antiretroviral therapy based on safety and efficacy profiles. And I know there are a number of audience questions related to this topic, so hopefully we can get to those. So let's start again with getting the audience's input. So which of the following statements is not correct regarding the rapid initiation of antiretroviral treatment? Is it 1, rapid ART initiation should only be offered to people living with HIV who do not have other comorbidities? 2, delaying antiretroviral therapy may impact transmission, opportunistic infections, morbidity, and mortality. 3, in a pilot program in a publicly insured clinic in San Francisco, 96% of patients accepted a rapid start treatment on the first day of diagnosis. 4, barriers to patients adhering to treatment were substance use, mental illness, and homelessness. Or 5, I don't know. Please take a few seconds to answer that question now. Okay, great, and we will come back to that. So Carlos, you have really championed and had success with rapid starts, rapid HIV treatment initiations in sexual health clinics. What are your goals and approaches to rapid start treatment?
So rapid ART initiation is something that we should really all be aiming for. The current treatment options make rapid starts a very safe option for most of our patients. So the goals are to be able to provide treatment early and to provide treatments of maximal potency and durability, which we are now able to do. The aim is to reach undetectable viral load as early as possible, which then will provide many different benefits. So it leads to improved health outcomes, reduced HIV transmission, as we now, we're all very familiar with the slogan of U equals U, undetectable equals untransmittable. And then also, as we achieve viral suppression, we are also able to achieve more rapid restoration and preservation of immune function. And of course, all of this contributes to reduced risk of morbidity and mortality.
Okay. And I think the next slide regarding the benefits, but often delays, I think, Leandro, maybe you can share with us your thoughts.
I think, one of the things about rapid ART, as we talk about these parts, rapid ART has the potential to be a great equalizer, because in the extent that we have protocols that offer ART to every person at the moment of diagnosis, we have talked, over and over how African Americans are less likely to be offered ART. So rapid ART, again, many studies on rapid ART were conducted in low resource settings outside of the US, in Africa or Haiti. And rapid ART is one of those areas where practice is really ahead of the science. and where many programs now in the United States are doing, rapid ART initiating patients, as soon as possible after diagnosis, with the goal of making sure, excuse me, making sure that people has medications in hand, within 7 days, as soon as possible, but at least, within 7 days of HIV diagnosis. And San Francisco General Hospital really was perhaps the earliest US model of rapid ART. They established in 2013 a pilot program with a safety net network of hospitals in San Francisco that they expanded to the city in 2015 as part of their San Francisco Get to Zero initiative. So they developed this protocol that optimized linkage to care and training of providers on why and how to initiate ART. No matter where people were in the city and they were diagnosed with HIV, they were taken to a provider who could start, who started antiretrovirals on the same day of diagnosis and was able to prescribe medication for 4 weeks. Then a linkage coordinator was able to connect this individual with a provider who will become their regular provider. Again, this is a model, and many cities are doing this in a different way. So what they saw was a 96% decrease in the median days from first care to ART initiation. It went from 28 days to 1 day, and a 48% decrease in the median days from first care visit to viral suppression, from 145 days to 76 days. And imagine the implications that this can have, for decreasing community viremia, right? And affecting the potential for HIV transmission. So by 2017, 28% of all new diagnoses in San Francisco had rapid start.
That's very, very exciting and very encouraging data. Leandro, can you also tell us what the guidelines recommend as far as rapid treatment?
Right. Both the DHHS guidelines and the IAS, USA guidelines endorse rapid ART. DHHS says that ART should be started as immediately or as soon as possible following diagnosis. They recommend not to use NNRTIs because of the high transmitted resistance to NNRTIs that exist in many communities. They recommend not to use abacavir for rapid ART because, again, you should not give abacavir until you know the HLA B5701 status of the person, to avoid allergic reactions, dangerous allergic reactions. And then they do not recommend yet the use of the dolutegravir 3TC because of the potential that people may be resistant to the NRTI if they have a 184B mutation. Nevertheless, there are some, already, emerging studies showing that dolutegravir plus 3TC could be used, with and medications can be, adjusted, a few days after if people are found to be, to have chronic hepatitis, so they may need additional treatment for hepatitis, or they have a 184B mutation. IAS, again, suggests same thing, initiating as soon as possible. And the caveat for rapid ART are individuals who have two opportunistic infections. One is cryptococcal meningitis, and the other one is tuberculosis. In both instances, people who have these two infections, you're supposed to hold antiretroviral therapy for at least 2 weeks after they have been treated for these infections to avoid worsening the situation. So again, the recommended regimens are several ones: bictegravir, TAF, FTC, co-formulated in one single tablet. I always prefer, and this data that you show from the trio, from the real world thing, one single tablet is better than multiple tablets for a number of reasons. In order to reach virology suppression, you can use dolutegravir, TAF or TDF plus FTC or 3TC, and you can use booster darunavir either with ritonavir or cobicistat plus TAF, TDF, or FTC, 3TC. The most important thing, and I look forward to hear, what Carlos, or you only do in your practices, is that I think it's important that in a clinic, everyone agrees what everyone is going to do. Be consistent with everyone does. I think that simplifies a lot of things, simplifies the messaging, because it's something that you want to talk to people. Again, as soon as you tell them, you're HIV positive, let's talk about the treatment that we can give you. You assess that person, is okay, and if they can process the information. But if they're okay on taking medication, which happens in my experience with over 90% of the people that I see, there should be no reason why you shouldn't give them medication right away. You make sure you follow up with them, and you confirm that they got the medication in hands, right? And then once they start taking the medication, many clinics will have a starter package so they can see you taking the medication, the first dose in the clinic, direct or cell therapy. If that's not possible, follow up with them. I always say, for many people, the HIV diagnosis, telling someone you have HIV is something very abstract. It becomes real when they have the medication bottle and they break down. So make sure you follow up with them 7 days later, check for side effects, and make sure you see them, 7 to 14 days after you start medication.
Great, thank you so much. Again, just to confirm or reaffirm that, you don't need the lab testing results and resistance testing results before you initiate treatment, that you can, as you said, make those changes once you have the results if you need to. And it seemed like in Jumpstart, for instance, very few people needed change in their regimen. Some questions from the audience are, can you do a rapid start in patients with HIV Hep C co-infection?
Yes, you can. Mm-hmm. No problem at all.
Yeah, our treatment options, will not actually hurt the patient with hepatitis C in any particular way. So, and in fact, now we have options that will also cover hepatitis B as well. So patients with chronic hepatitis B, with a lot of our options that include tenofovir, TAF-FTC, for example, then that appropriately treats the hepatitis B. So as we get the results, then, we explain to the patient, we also find that you have chronic hepatitis B, this treatment will also take care of the hepatitis B, will control your hepatitis B. But for hepatitis C, that's not a reason. So we should be testing for viral hepatitis or hepatitis C and hepatitis B, but it's not a reason to delay initiation of ART.
Right, thank you.
I think, again, besides the two comorbidities that I mentioned, cryptococcal meningitis and tuberculosis, the only really reason why I wouldn't give someone rapid ART or initiate it rapidly is when the patient tells me, I'm not ready for that. I mean, you have to be respectful and you say, well, let's check in, in 3 days, and let's see where you are. Again, the idea is to start ART as soon as possible, starting by right away.
Okay, great. So a question that came in from the audience that is going to be covered next is, we know that INSTIs are the drug class that has provided the highest rates of viral suppression among all groups, including Black people, but weight gain we know can be a problem. Carlos, can you share the analysis, the results about weight gain from HIV treatment involving INSTIs and compared to other types of regimen?
Sure. So we now have multiple studies that have shown that there is, in fact, an association of weight gain with integrase inhibitors. So we have clinical trial data. We also have data from multiple cohorts around the US and also around the world, which clearly show that it is, in fact, a class effect. That INSTIs overall do increase weight in patients starting on them. However, what's not so clear is exactly who will be gaining more weight. And we're still working that out as to, what are the risk factors? Who are the patients who are more likely to gain weight? So here, we're showing results from different clinical trials, which all consistently show an association of weight gain with initiation of INSTIs. For example, in the Gilead 1489 and 1490 studies, the combination of bictegravir led to a median increase of 3.6 kilograms in weight, but also in the comparator group, we also saw a weight gain with dolutegravir of 2.4 kilograms, and in the 1490 study, very similarly, about 3.5 to 3.9. So it's still not clear that one integrase inhibitor will cause necessarily more weight gain than others. It's very likely that dolutegravir and bictegravir are associated, with significant weight gain. But we will also see that as well with elbictegravir and even raltegravir. basis. So, that data is a little more equivocal, but it does seem to be a class effect, in fact. And there may be also contribution of tenofovir alafenamide, so the addition of TAF. So the study all the way to the right was the advanced trial that was conducted in South Africa. This was a very interesting study. So it included both men and women. Almost all of them were Black. And patients were randomized in this study. So this was an initial treatment to receive either dolutegravir plus tenofovir alafenamide with emtricitabine, or dolutegravir plus TDF with emtricitabine, or efavirenz TDF with emtricitabine. And what was clearly seen is that the least amount of weight gain at the end of the first year, and even going on to 2 years, now there's 2-year data, was with the efavirenz regimen. And in the case of dolutegravir, there was a more significant weight gain. And in the case, it was seen that it was 5 kilograms was the mean weight gain at 1 year for dolutegravir plus TDF and FTC. But then with exactly the same regimen, except that it was TAF instead of TDF, then the weight gain was even more. Which then suggests that TAF itself may be leading to increased weight. And what was also very interesting about that study is that since there were enough participants, so the distribution was about 50-50 or a little bit higher percentage of women, then they could do an analysis looking at men and women. And in women in particular, we saw that the weight gain seemed to continue beyond even the first year, whereas for men, it seemed to plateau towards the end of that first year. So overall, this does seem to be, a real effect. It is not yet clear exactly, who is at highest risk. But, and I think this should be made very clear, it is actually not a reason to not start somebody on an INSTI. We just went over why INSTIs are, in fact, recommended as first-line therapy. They're extremely potent. They're very safe. And for those reasons, then it still makes sense to keep them as first line. But it is important to counsel patients and explain that there may be weight gain observed, and it is important to then also do what we would recommend of anybody to, engage in diet and exercise and to try and manage that weight. And if we look at the next slide, then we can see as we delve more into trying to understand who is at more risk, then we can see that this pooled analysis by Sachs and Paul Sachs and co-authors that clearly showed, and this was a pooled analysis of 8 different clinical trials, and it showed that women were at higher risk or were more likely to gain weight than men, and this is through 96 weeks. And in particular, when we look at Black women compared to either Black men or non-Black women and non-Black men, we see that that was the group that gained the most weight over that period of time across these different studies. So for our African-American women that were starting on antiretrovirals, it is important to explain that we are using a very safe and potent regimen, but there is some risk of weight gain that we should be monitoring and counseling the patient about as we treat them for HIV.
Great, thank you so much. Lots of good information about INSTIs. And then also, the potential for long-acting injectables to improve some of the health outcomes that we see among people living with HIV, and really the introduction of long-acting injectables as potential game changer and a paradigm shift for several reasons, including the fact that they require infrequent dosing, have potential to improve adherence to antiretroviral therapy. There's a lower overall drug dose that's given, less pill burden, so patients are less likely to have to deal with treatment fatigue, the potential for directly observed therapy in the clinical setting, and then potentially reducing stigma as well. So So antiretroviral therapy, obviously is moving in the direction of long-acting options. Carlos, what can you tell us briefly about the Atlas 2M study and others like it?
Sure. So we know that now, based on the results of the Atlas and FLAIR studies, that the long-acting injectable regimen of long-acting cabotegravir and rilpivirine has been approved for dosing once a month. Participants or patients would who are virally suppressed are then able to switch to this regimen where they only require an injection once a month. And this is now FDA approved in the US. But now we also have data from the Atlas 2M study, which was presented at the CROI conference. And it showed that with higher dosing, but that could be spaced out even more, all the way out to every 2 months instead of once a month. And then what we see in this snapshot is that the every 8-week dosing was non-inferior to every 4-week dosing. Essentially, we achieved just as high virologic success, in the 90% range, with very, very low virologic non-response. So this is not yet approved. However, we expect that, based on this data and the fact that it's non-inferior, that this will be an option coming up in the future, where patients will be able to then switch to a regimen if they prefer, where they would only require a long-acting injectable dosing every 8 weeks. And this is the direction that the field is going overall. At the recent CROI conference, and there was data also on other experimental drugs that are being evaluated for long-acting use, where it may be possible in the future to dose some of these upcoming drugs as infrequently as every 6 months. So, which I think is very exciting. Short of having a cure, having these options of less frequent dosing is really what we need to be able to provide for our patients to decide what makes sense for them.
Agree. Thank you. Very exciting. So the BRAVE study, we're going to move on to the BRAVE study. It's one of the first trials to look at resistance following switching antiretroviral therapy in Black people living with HIV. What can you tell us about this study, Leandro?
This is a really interesting study. I think, is the fact that many of the data from clinical trials that we've been discussing, right? It's really doesn't really include, most of the studies, include very few, individuals of African Americans in the study. So we know that African Americans or Black Americans have been, have the highest rates of HIV infection, and they continue to be underrepresented in clinical trials. So this study, evaluated the safety and efficacy of switching to Bictegravir FTC TAF among Black adults. And this was a randomized, open-label, active control phase 3 study that evaluated switch from baseline regimen that very often was 2 NRTIs plus a third agent to Bictegravir FTC TAF in individuals who were virologically suppressed. The NRTI backbone was FTC TAF for 67% of individuals, FTC TDF for 19%, and Acavir 2TC for 14%. The third agent was the integrase inhibitor for 59%, NRTI for 29%, a PI for 6%, and other 6%, which is very consistent to what we see in clinical practice. In terms of baseline ARV resistance, as you can see, there were no significant differences between those who were switched to Bictegravir FTC TAF and those who continue in their baseline regimen in reference to NRTI resistant Promar, the M184V or I mutation, or NNRTIs, or PIs that were very consistent among the groups. So what you see here in the bars to the right, the 24 virologic outcomes, is that switching to Bictegravir FTC TAF was non-inferior to remaining on the baseline regimen at week 24. Patients with a baseline NRDL resistance remain suppressed. And again, I think it's important from the perspective that it really included, it was a study among that included only African American patients that are very often excluded, for many clinical trials in our country.
Thank you, Leandro. And also, we know that a prodrug that can be added to existing antiretroviral therapy regimens to break through multi-drug resistance may be one of the upcoming game changers. What do the data tell us about who this prodrug might help?
Yeah, fostensavir is the prodrug of the active drug temsavir, which is first-in-class attachment inhibitor. They tested for multi-drug resistant HIV infection in 2 cohorts according to their remaining treatment options. So in the first cohort, the randomized cohort to the left was for patients who had the option of using at least one fully active approved antiretroviral drug in at least one, but no more than 2 antiretroviral classes, to either fostemsavir, a dose of 600 milligrams twice daily, or placebo, to the failing regimen for 8 days, followed by open label fostemsavir plus optimized background therapy. In the second cohort, you can see to the right, patients who had no remaining antiretroviral option were started on open label fostemsavir plus optimized background therapy on day 1. This was a non-randomized cohort. And the primary endpoint was the mean change in HIV RNA level from day 1 to day 8 in the randomized cohort. And what we see here is, again, these patients had with 48, a virologic response of 50% of individuals in the randomized cohort had a decreased a viral load that was less than 40 COVID per ml, and in the a non-randomized cohort it was 38%. So again, for individuals that have one choice or no choice at all, fostemsavir as a new class of drug really presented an alternative that may improve virologic outcomes in those individuals.
Okay, thank you so much. So let's revisit our polling question. Which of the following statements is not correct regarding rapid initiation of antiretroviral therapy? Is it, and I think I read the different options. Yes, so we'll see if it's one of the options it is. Great, thank you. So hopefully everyone was able to select the correct answer, which is not correct regarding rapid initiation treatment. It's that rapid initiation should only be offered to people living with HIV who do not have other comorbidities. That is correct. Okay, good. So let's summarize with takeaways and action steps. That is what I hope that you will take away from this presentation to apply to your clinical practice. You know that rapid antiretroviral treatment or initiation of ART immediately or as soon as possible following diagnosis can be started without labs or resistance testing results. And we know that INSTIs provide the best viral suppression among Black Americans, but weight gain can be an issue. So thank you again so much to my colleagues, Carlos and Leandro. Thank you. We've had a great discussion. Now let's answer more of our, I guess we're going to move on. Actually, I realize we're out of time, so we're not going to be able to answer more of your questions, but hopefully at a subsequent CME event. So to receive CME and continuing education credit for today's program, please complete the post test on your screen and then click Request Credit tab to complete the evaluation and print or download the certificate. Then also visit the Infectious Disease Hub for additional activities on HIV for clinicians, and you can see the website address there. And we have tons of resources in both English and Spanish for patients about HIV prevention and treatment, including videos, checklists, and an animated whiteboard. And we're always adding new things. CME Outfitters has your patients covered with vetted resources created under the guidance of experts. And so lastly, speaking of education, please invite your patients to join me on Tuesday, May 4th, when I will take over the Instagram account of CME Outfitters at noon, 12 noon Eastern Standard Time on May 4th. I'll be live and patients can ask me anything about PrEP. My goal throughout the day will be to provide information and resources to patients wondering about PrEP, and really encouraging individuals to get tested for HIV, and if HIV negative, taking action to prevent HIV. I think it'll be a lot of fun, so please spread the word to your patients. Again, thank you again, Carlos and Leandro, for joining me. Thank you to CME Outfitters for their assistance in putting together this program. And thank you to our audience for joining and providing the best care for your patients with HIV. Have a good evening.
Bye.